next speaker is Dr. Nichlani VK. So he'll be speaking on the novel approach of managing posterior polar cataract by eliciting floating sign and avoiding PCR. Over to you.
Good morning, dignitaries. I'm Dr. Paresh Nichlani, co-author. I'll be speaking on behalf of Dr. V.K. Nichlani. The aim is to explore the details of different characteristics of posterior polar cataract and how to avoid the dreaded complication of PCR with the novel approach of floating sign. So a pre-op examination, as we do in all the cataract surgeries, mandate, but the one in these cases is to know the anatomy and the morphology of the posterior polar cataract, the size, the onion peel appearance, halos around the posterior polar cataract, radial stretching lines, fishtail sign, and sometimes the white flaky material can be seen behind the cataract. Posterior polar cataract is known for leading cause of PCR. In varying studies, 25 to 30% have been noted. These studies establish the efficacy of floating sign in avoiding PCR and explore various details of posterior polar cataract. So total 136 cases were observed in last 26 years. The age of the patients were from 40 year to 78 year. Majority of them being male, and majority of the cataract nucleus sclerosis was grade 1.
Just a clarification. In the directions it is written that changing of presenting author is not allowed. So we cannot allow this presentation.
What is your name?
Sir, Paresh Nichlani.
Yeah, but you are neither the chief author nor the presenting author, right? So it's not allowed for this presentation.
So if you have to do this presentation, you have to take permission. That too at least 3 days prior. Or
last moment, so they have mailed, but we didn't got the.
okay, so we are so sorry you cannot present. Yeah.
I don't mark it, I'll just present.
Fine.
Okay, but we'll not be scoring. You can
Yes,
just
yes,
present your
definitely.
presentation at the time.
Thank you, ma'am. So the exclusion for these cataract were any pre-operative posterior capsular dehiscence which were observed on slit lamp examination. So these were the observation. Never touch the posterior plaque with phaco tip because it can lead to sudden suction and you can end up in a posterior capsular rupture. When there is a thick hard cataract and it is difficult to separate the nucleus from the epinucleus, so never try much of a rotation of your nucleus or you can land up in this situation. Always avoid active pulling or pushing of the last epinuclear plate or the cortex, which can lead to posterior capsular dehiscence, as you can see here. Never ever try to polish the zone where the posterior plaque was present, because the posterior capsule there is already weak and it can lead to dehiscence. So what we learned using this floating sign is that first clear up the cortex without doing any hydro procedure, and at the level of the nucleus do hydro delineation and separate the nucleus from the posterior cortex or the posterior epinuclear plate. Then manage this nucleus like we do in a normal phaco surgery. Just keep few things in mind, that your AC should never decompensate. The nucleus should not be rotated very aggressively or vigorously. And once you have cleared up this central nucleus, then there is good amount of space in your capsular bag. So now take, after managing the nucleus, take your irrigating port just at the plane between the anterior capsule and the cortex, and with this passive hydration the fluid gush goes at the level of the plaque, and because there is much space anteriorly, the capsular bag is already empty, the force which is generated at that level pushes the plaque upwards rather than pushing the weak posterior capsular bag for dehiscence, and this we have named as a floating sign. So again, to demonstrate the same sign, after managing the nucleus, just do this active hydration passively. So what happens, again I'll explain, this active fluid goes at between the posterior capsule and the cortex and it lifts up the capsule because there is enough space anteriorly. So with this technique, out of all the cases, we had only 2 posterior capsule rupture, and those cataract were also a grade 4 cataract. So as I have explained in the video, posterior capsule is weak at the level of plaque but not deficit in all cases. The hydrodissection in such cases allow the weak plaque area to give away, as the wave could not move further because the bag is already occupied with the nucleus. But when the bag is emptied of the nucleus, the resistance decreases as shown in figure 2, and with a good passive hydration, there's no active force on the posterior plaque. With the passive hydration, the weak area does not go posteriorly but it floats the plaque anteriorly, and hence preventing the posterior capsular rupture.
Okay, thank you,
Thank
Dr.
you. Thank
Paresh.
you,
That
ma'am.
was indeed a good presentation, and hope you come up as the presenting author for the next AIOC.
Sure, sure.
Best wishes. Thank you.